Welcome to Third Rock Ultrasound. Since 1998, Third Rock Ultrasound has presented educational programs to help clinicians integrate ultrasound technology into their patient care, with thousands of courses teaching thousands of healthcare professionals at worldwide locations. This is Module 10, First Trimester Pregnancy.
Ectopic pregnancy is still one of the leading causes of maternal death, but ultrasound has dramatically decreased the morbidity and mortality of this disease.
This module will help you use ultrasound to manage first trimester pregnancy complaints.
Let's start this module with a case. A 22-year-old female presents to the emergency department for pelvic pain and pressure. Her last menstrual period was 9 weeks prior, and her urine pregnancy test is positive. Her physical exam is unremarkable. There's only a mild amount of tenderness on palpation over the symphysis pubis, and there are no peritoneal signs. She has no vaginal bleeding or discharge. This is her transvaginal ultrasound. So, what do you think? We will return to this case at the end of the module to see how it turns out. The objectives for this module includes the ultrasonic evaluation of normal pregnancy, abnormal intrauterine pregnancy, and ectopic pregnancy. We will also discuss the management strategy you will use to manage these patients based on your ultrasound exam. First, let's discuss normal intrauterine pregnancies. There are two approaches to ultrasound examination of the pelvis, transabdominal and transvaginal. In general, embryonic structures will be seen about 10 days earlier by transvaginal ultrasound versus transabdominal ultrasound. So, what will be the first structure you will see with a normal intrauterine pregnancy? The first embryonic structure you will see is the gestational sac. Here's an example of a gestational sac with an intrauterine pregnancy. The uterus is easily identified and the sac is clearly within the uterus. There will be two hyperechoic rings of tissue around the gestational sac that is caused by trophoblastic cells growing into the endometrium. The inner ring is called the decidua capsularis, and the outer ring is called the decidua vera. It is imperative to understand that a gestational sac alone is not a guarantee of an intrauterine pregnancy. As you will see, there is a similar structure that sometimes appears in ectopic pregnancy. The second embryonic structure seen by ultrasound is the yolk sac. On ultrasound, the yolk sac looks like a small balloon. This structure supplies nutrients to the growing embryo. The yolk sac will be seen between 5 and 6 weeks by transvaginal scanning and will disappear by the end of the first trimester. One important point is that an intrauterine yolk sac is definitive proof of an intrauterine pregnancy. This video demonstrates a normal intrauterine pregnancy. The gestational sac is in the uterus, it has a double decidual sac sign, and a yolk sac is clearly seen. The third embryonic structure seen by ultrasound is the fetal pole. In this image, you see an intrauterine gestational sac with a yolk sac and a fetal pole. This video shows a fetal pole in a normal intrauterine pregnancy. The fourth ultrasound finding is not a structure, but is rather the presence of fetal heart motion. The presence of fetal heart motion is an important prognostic factor, since pregnancies that have fetal heart motion only have an incidence of spontaneous abortion of about 10%. Here is a video from the first trimester of pregnancy which demonstrates fetal heart motion. Let's review when each of these structures will be seen during gestation of a normal pregnancy. This table shows when the four findings of normal intrauterine pregnancies will be seen by transvaginal and transabdominal ultrasound. As noted earlier in the module, these findings are seen about 10 days earlier by the transvaginal approach. The reason that an intrauterine sac of fluid is not an absolute indicator of an intrauterine pregnancy is because of the finding called a pseudogestational sac. A pseudogestational sac is a reaction of decidual cells in the endometrium that is seen with ectopic pregnancy. A pseudogestational sac will not be present in all ectopic pregnancies. This is an image of just such a sac. Here is a video of a pseudogestational sac. You can see the surrounding endometrium is thickened, but that there is not a ring of hyperechoic tissue around the sac, nor any evidence of embryonic structures. Here are two important considerations for pseudogestational sacs. The first is that they are very small, typically less than 10 millimeters in size. The second is that they are very rare compared to the presence of a gestational sac with a normal intrauterine pregnancy. Now, let's consider how you can use ultrasound to facilitate gestational dating in the first trimester of pregnancy. There are two measurements of embryonic structures we will consider for this module. The first is the size of the gestational sac, and the second is the crown to rump length. The gestational sac grows about 1 millimeter per day after implantation. The formula for estimating the gestational age based on the size of the gestational sac is the mean gestational sac diameter in millimeters plus 30. This number will give you the gestational age in days. In this example, we see the sac diameter is 19 millimeters. Therefore, 19 plus 30 equals 49 days, or 7 weeks gestation. Of note, when measuring the gestational sac, you do not include the hyperechoic rim of trophoblastic tissue in the measurement. The crown to rump length of the fetus is the most accurate method to calculate the gestational age of the pregnancy, and you should attempt to get this measurement whenever possible. To do this, you often cannot determine what is the actual crown or rump of the fetal pole, so measuring the longest dimension of the pole without including the yolk sac is appropriate. Using the calculators found in nearly all ultrasound systems, the gestational age is easily determined. Next, we will discuss the findings associated with abnormal intrauterine pregnancies. By way of introduction, it's important to remember that 1/3 of all pregnancies end in miscarriage. Miscarriage is usually caused by problems associated with the mother, fetus, or placenta. There are a number of confusing terms which describe conditions of abnormal first trimester pregnancy. Complete abortion is when all products of conception are expelled. The uterus is empty on ultrasound, and on physical exam, the cervix is closed. Incomplete abortion occurs when some of the products of conception have been expelled from the uterus. However, some of those products of conception are still evident in the uterus on ultrasound. With threatened abortion, there is still a viable intrauterine pregnancy seen by ultrasound. However, there's some other issue present that puts the pregnancy at risk. Missed abortion is when a non-viable intrauterine pregnancy is seen by ultrasound, and the products of conception are still within the uterus. An inevitable abortion is when the cervix is dilated and there are some products of conception within the uterus. Septic abortion is classically seen with illegal abortion, but can be rarely seen with intrauterine devices. The patient also has evidence of infection, including fever, purulent discharge, abdominal pain, and a leukocytosis. Now let's look at 4 ultrasonic indicators of failed intrauterine pregnancy. The first is a blighted ovum. This is seen when the gestational sac by ultrasound is greater than 20 millimeters and there is no evidence of a yolk sac or fetal pole. Here is an example of a blighted ovum by ultrasound. This is not a viable intrauterine pregnancy. The second indicator of a failed intrauterine pregnancy is a subchorionic hematoma. A subchorionic hematoma is seen when the chorion and the endometrium separate. Many pregnancies have small subchorionic hematomas that develop normally to full-term births. However, when the hematoma's surface area covers more than 50% of the chorion, it puts the pregnancy at a very high risk for abortion. When this occurs, blood collects between these two structures. In this image, you see fluid around more than 50% of the gestational sac. This video demonstrates a very large hematoma covering more than 50% of the surface of the chorion. Here we see an intrauterine pregnancy with a smaller subchorionic hematoma. The third indicator is intrauterine fetal demise. Intrauterine fetal demise is diagnosed when an intrauterine pregnancy is greater than 7 weeks gestational age with no evidence of fetal heart motion. This video shows an example of intrauterine fetal demise. You can see there is no evidence of fetal movement or fetal heart motion. The final indicator is the presence of an intrauterine mass that is not a component of a normal intrauterine pregnancy. On ultrasound, the examiner will see an unrecognizable intrauterine mass with or without vaginal bleeding. One example of an intrauterine mass is a molar pregnancy. This is a gestational trophoblastic disease where aberrant fertilization occurs, causing profound chromosomal abnormalities that will yield a non-viable pregnancy. A hallmark of the disease is the production of very large quantities of human chorionic gonadotropin, or HCG. Molar pregnancies are uncommon and have an incidence of 1 per 1,000 pregnancies. Patients with molar pregnancy will often present with hyperemesis gravidarum, preeclampsia before 20 weeks gestation, and an enlarged uterus. There are two genetic types of molar pregnancy, complete and partial. Complete molar pregnancies always have the hydropic vesicles classically seen on ultrasound. There is no fetus present, they have more symptoms, and a very high HCG, often greater than 250,000 milli-international units. Partial molar pregnancy do not always have the hydropic vesicles. They may have a non-viable fetus and have less symptoms and lower HCG levels than complete molar pregnancies. This brings up an important consideration with regard to HCG levels in pregnancy. What is typically the peak quantitative level of a single normal intrauterine pregnancy, and when does the HCG level peak during pregnancy? For a single normal intrauterine pregnancy, the HCG will peak at the end of the first trimester at about 100,000 milli-international units per milliliter. It is important to be aware of this when using the HCG level to assess the status of any pregnancy, particularly in first trimester. The overall prognosis for most cases of molar pregnancy is good. 80% are benign and can be treated by terminating the pregnancy. About 10 to 15% are locally invasive and will require chemotherapy, and about 2 to 3% will progress to choriocarcinoma. This image shows the intrauterine presence of hydropic vesicles. As you would predict, it appears as multiple fluid-filled structures. This is a video with a transabdominal view of a molar pregnancy. Here is a transvaginal view of a molar pregnancy. This patient's HCG level came back at over 450,000 milli-international units. In this section, we will discuss the diagnosis and management of ectopic pregnancy. Ectopic pregnancy remains the #1 cause of maternal death from pregnancy. However, with ultrasound, the morbidity and mortality of this disease has plummeted over the past 4 decades. So what will you see on ultrasound with ectopic pregnancy? On ultrasound, the examiner should look for a non-gravid uterus, an extrauterine mass, and free intraperitoneal fluid. However, you do not need all 3 findings to make the diagnosis. The classic finding is an adnexal ring-like mass. Unfortunately, this is seen in the minority of cases of ectopic pregnancy. Here is an example of an extrauterine adnexal ring-like mass. Here is the uterus, and the mass is here. You can even see a yolk sac within this mass. This is a more advanced case of ectopic pregnancy. The uterus is here, and a fully developed embryo is clearly seen outside the uterus. In this video, we see 2 extrauterine cystic structures below a non-gravid uterus. The ectopic pregnancy is on the right side of the screen and contains a yolk sac. In this video, we see the ectopic pregnancy on the right side of the screen. If you look closely, you can see fetal heart motion in this mass. This is a great video of an ectopic pregnancy. You can see a fully developed embryo with fetal heart motion. Free intraperitoneal fluid will be seen with ultrasound as the ectopic pregnancy begins to leak. This is a transabdominal view of the pelvis in a case of ruptured ectopic pregnancy. The uterus is clearly outlined by blood both anterior and posterior to its location. The urinary bladder is seen on the right side of the image. Here's a transvaginal view using a coronal orientation in which rupture has occurred. The fluid collection at the top of the screen is urine in the bladder. The free fluid below the bladder is blood which surrounds the uterus. This is a transabdominal ultrasound in the sagittal plane of a ruptured ectopic pregnancy. Blood clots and free fluid can be seen surrounding the uterus. With this information, we can utilize a rule-out ectopic pregnancy protocol. The management strategy is to rule out ectopic by ruling in intrauterine pregnancy. Using this strategy, we will be able to quickly rule out ectopic pregnancy in 2/3 of the cases that present to the emergency department. An important consideration when using this protocol is the risk of heterotopic pregnancy. Heterotopic pregnancy is very rare and only occurs in roughly 1 in 6,000 pregnancies. An important caveat to remember is that for those patients undergoing fertility treatments, the risk of heterotopic pregnancy can be as high as 1 in 100 pregnancies. The goal of the overall management strategy we will teach you to use is to establish one of 4 diagnoses. Those diagnoses are definite intrauterine pregnancy, probable abnormal intrauterine pregnancy, definite ectopic pregnancy, and no definite intrauterine pregnancy, or just simply, I don't know. To establish the diagnosis of definite intrauterine pregnancy by ultrasound, the examiner should look for the following 3 characteristics. A gestational sac with a sonolucent center greater than 5 millimeters, the pregnancy must be located in the uterus, and the pregnancy must contain at least a yolk sac and or fetal pole. To establish the diagnosis of abnormal intrauterine pregnancy by ultrasound, the examiner should look for a gestational sac within the uterus, a gestational sac diameter greater than 20 millimeters without a fetal pole, or a fetal pole without fetal heart motion. To establish the diagnosis of definite ectopic pregnancy by ultrasound, the examiner should look for a ring-like mass that is not in the uterus and contains a yolk sac and or fetal pole. However, there will be cases where what you see does not meet any of these criteria. Now you must acquire a quantitative HCG measurement to assist in managing this patient. In 1981, Cater and his colleagues established a very important concept for the sonographic evaluation of ectopic pregnancy called the discriminatory HCG zone. This concept stated that for a discriminatory cutoff value of beta HCG, an intrauterine pregnancy should be visible on ultrasound. The discriminatory HCG zone has used different values as cutoffs for different stages of pregnancy. At 5 weeks since the first day of the last menstrual period, an HCG value of 1,800 milli-international units should demonstrate evidence of an intrauterine pregnancy by transvaginal ultrasound, and this includes a gestational sac and perhaps a yolk sac. This value has changed significantly over the past 2 decades with improvement in ultrasound technology. Currently, a value of 1,000 milli-international units is most commonly used. At 6 weeks since the first day of the last menstrual period, an HCG value of 7,200 milli-international units should demonstrate an intrauterine yolk sac by transabdominal ultrasound and a fetal pole and fetal heart motion by transvaginal ultrasound. At 7 weeks since the first day of the last menstrual period, an HCG value of 21,000 should demonstrate fetal heart motion by both transabdominal and transvaginal scanning. By applying this data to patient management protocols, we can establish a management algorithm for rule-out ectopic pregnancy. If a pregnant female with a relevant complaint presents and there is ultrasonic evidence of either a definite intrauterine pregnancy or abnormal intrauterine pregnancy, then the patient's complaints are treated and she is referred to obstetrics for outpatient management. However, if the patient has any of the following conditions, obstetrics should be consulted. They include intrauterine device, history of bilateral tubal ligation, infection, moderate to large amounts of free intraperitoneal fluid, or a suspicious adnexal mass. If the patient has a definite ectopic pregnancy, then you would obviously consult obstetrics immediately and prepare the patient for surgery. If the patient does not meet any of these criteria, then the HCG level should be measured. If the HCG level is less than 1,000 milli-international units, the patient can be discharged home with precautions to return and follow up to recheck the HCG level and repeat the ultrasound. If the HCG level is greater than 1,000 milli-international units, then obstetrics should be called to discuss the case. There are many pitfalls to the management of ectopic pregnancy. We will now review some of those issues. The history is not a reliable method for determining the presence of ectopic pregnancy. The only symptom present in more than 90% of patients with the disease is a history of abdominal pain, which is completely nonspecific. No other symptom has an incidence of greater than 60%. In addition, physical exam findings are also not reliable for determining the presence of ectopic pregnancy. The only sign present in more than 70% of patients with the disease is abdominal tenderness, meaning you can miss nearly 1 in 3 cases if you use this to rule out the disease. No other physical sign has an incidence greater than 60%. The most common mistake seen when misdiagnosing ectopic pregnancy as a normal intrauterine pregnancy is to overlook that the pregnancy is not located in the uterus. Edema can cause the fallopian tube to swell and fool the examiner that an intrauterine pregnancy is present. This image is an example of just such an ectopic pregnancy that fooled the examiner. In this video, the patient appears to have an intrauterine pregnancy at first, but when you scan through the entire abdomen, you can see that the pregnancy is extrauterine. Be sure to carefully consider HCG levels. Up to 1/3 of ectopic pregnancy will be diagnosed with an HCG level less than 1,000 milli-international units. Even a small amount of free intraperitoneal fluid seen on ultrasound may represent a leaking ectopic pregnancy. Here is an excellent example of this phenomena. This patient presented 3 weeks after her last menstrual period with pelvic pain. Her urine pregnancy test was positive, and her quantitative HCG ordered in triage was only 272 milli-international units. Her hemoglobin, also ordered in triage, was normal. This is her transabdominal ultrasound in the sagittal plane, and as you can see, it is normal. This is the cervix, this is the uterus, and the rectouterine pouch is empty. Here is the axial view. Again, this looks normal. Here is the uterus, and here are her ovaries. However, as you plane down into the pelvis in the axial plane, you see intraperitoneal fluid. This amount of free fluid in the pelvis is enough to consult gynecology, and this patient subsequently went to surgery where an ectopic pregnancy was found. Okay, it's time to return to the opening case for this module. As you will recall, this was a 22-year-old woman whose last menstrual period was 9 weeks prior and presented for pelvic pain and pressure. Her physical exam was unremarkable. Here is the transvaginal ultrasound in the sagittal plane. You can see a non-gravid uterus here and an extrauterine fetus here. This is the coronal view of the uterus. There is no evidence of an intrauterine pregnancy. On closer examination of the ectopic pregnancy, you can see fetal heart motion. So, the patient has 2 IVs placed, she's typed and crossed for blood, and taken to the operating room.
So that wraps up first trimester pregnancy. And so as we've done in the past, we're going to follow up with some pointers. Tom, how many this time?
We got 3.
We got 3 pointers this time. So Tom, I'll let you take it away.
Thanks, Pat. So the most important skill you can have when you're ultrasounding the pelvis in first trimester pregnancy is to have the ability to differentiate the gravid from the non-gravid uterus.
It's a great point. The second point I want you to remember is to use the beta HCG discriminatory zone, because you've got to use that information to apply that to your ultrasound to determine exactly what you're looking at.
And finally, when in doubt, make sure you involve your obstetrical colleagues in these cases where you're not sure. Either that or have the patient come back to the emergency department in 1 or 2 days or for any other concerning signs or symptoms.